Hi, my name is Ron Blankstein from Boston, and it is my pleasure to introduce this webinar that we're going to do today. This is a webinar on behalf of SCCT, cardiovascular business, and radiology business. And I'm delighted to have a superstar panel to join me in the webinar. So I'm going to ask every panel member to introduce themselves. We'll start with Dr. Ferencik.
Maros Ferencik. I'm a professor of medicine and radiology and section head of cardiovascular imaging at Oregon Health and Science University, and I'm the current president of the Society of Cardiovascular CT.
Hi, good morning. Christina Fuß here. I'm a professor of radiology and in the Department of Radiology and Biomedical Imaging and the division chief of cardiothoracic imaging at Yale University. And I'm also the current secretary of the Society for Cardiovascular CT.
Good morning, everyone. Michael Cords. I'm the medical director for cardiac imaging, RadNet West.
So welcome everyone to the webinar that we have today. It is a very special webinar because CMS just released their payment rule for 2025. This is, in fact, an exciting time for the field of cardiac CT because after many years of advocacy on behalf of SCCT, ACC, and ACR, we have witnessed a significant increase in payment. Specifically, what we're going to see in 2025 is that the payment for our cardiac CT code, so 75572, 73, and 74, is going to increase for the technical payment from $175 to $357. So that's over a doubling in that payment, and this is a payment to the hospital. This is under the hospital outpatient prospective payment system. For the physician fee schedule, we also saw an increase, and that increases from $285 to $318, so a 12% increase there. For FFRCT, under the HOPS program, FFRCT has had a slight increase in payment of 2% from $997 to $1,017. And then for plaque analysis, the payment remains similar at $950. Under the physician fee schedule, that's still up to the max to determine. So very beneficial changes and ones that are a direct result of advocacy for several years, requesting CMS to move cardiac CT to a more appropriate APC, and APC that actually aligns with the resources that are used when cardiac CT services are being performed. So with that, let's turn to our speakers.
This is really going to change how groups approach cardiac imaging and being able to provide better access to patients because, as you mentioned, for all those reasons, cardiac imaging was under-reimbursed, and it really created a barrier for many groups to start offering this service line. So where things are going with this and the impact is going to have, finally, we're going to be able to really make an impact on the leading cause of death in the U.S. It is far long, just overdue, where we're able to divert resources into catching this early, appropriately treating patients, and honestly saving the healthcare system money along the way, because we're going to be able to take these patients, treat them appropriately, and prevent the downstream expenses related to it. So how this affected my practice over the weekend, we've already had meetings this week regarding the new codes, how we're going to make sure we're tracking them correctly, how we're going to make sure that we're reimbursing. RadNet being in multiple different states, we have to deal with different MACs, how we approach different payer groups. So this is a lot to digest, but it's important that every group get ahead of this early, that they're able to capitalize on this and figure out what is best for their group to be able to offer this service line to the patients.
Let me ask Maros, you are the SCCT president right now, and this comes out. I'm sure you've gotten a lot of questions, and I think in your own group, people have asked you, what are the implications of this for the field? Do you want to share your thoughts on that?
Yeah, thank you, Ron, and thank you, Michael, for the introduction of this. Very positive for our field. I think I would just echo what Michael said. What we need to be ready for is to create system under which we are actually billing under this correct APC category. This includes meeting with our administrators, talking about this, making sure that within our computer system and billing systems that have softwares to support our billing, the changes are appropriately made. Unfortunately, in the next 12 months, we will have to deal with the rejections and repeals and potentially appeals to get this paid. We have to be ready that some of the initial submissions for the reimbursement will be at local level rejected, and we will have to create system how to deal with it. From the society perspective, we will be here to provide some of the resources that will teach or provide sites with the help to get this done. We will be also the hub to collect the data on a reimbursement rejection and provide this back, feed this back to CMS. This is actually what CMS is looking for. They are looking for to learn about how this system works in practice. And they, as the central institution, are supportive of this transition, but they will need information from us, from both the sites that perform the tests, as well as the society, to learn about when this doesn't work and how it doesn't work so we can fix it. So these are critical issues. What I would also emphasize is this provides a possibility for expansion in the areas of the country, in the areas that are probably underserved at this point. The change in the reimbursement will allow to start new services at the sites that were not able to absorb this higher cost of CT with previous reimbursement rates. So this is really an opportunity to serve the communities that would benefit from cardiac CT in the future that are underserved at the moment.
Michael, one point that sometimes is not clear for everyone is the fact that everything we're talking about today, whether HOPS or the MPFS, is under Medicare. What are the implications of this for private payers?
That's a great point. And, our focus has been, it's been great that for a hospital outpatient, technical component doubled and, physician fee schedule increased by 12%. That's great. It's going to be for all different reasons that we mentioned before. When it comes to private payers, that's something we need to keep an eye on. And that's something that my group is going to be actively reviewing every single month to see what changes we have when it comes to different reimbursement. And we have a variety of ranges when it comes to reimbursement that we're seeing from different payers. And I hope that over time that's going to continue to follow CMS and continue to go up as it should be appropriate, allow for better utilization, just for the same reasons that CMS increased their reimbursement. But I have yet to see any updates from private payers related to this. Obviously, it's still very new from CMS just happening a few days ago.
Let me turn to Christina next. I think a lot of what we've been talking about for the last couple of years is the increased adoption of coronary CTA, and certainly one aspect that is a contributing factor is the new chest pain guideline. I guess they're not that new anymore. They came out in 2021, and we certainly saw an adoption of CT that started even before these guidelines came out. Christina, what have you seen in your own practice in terms of adoption of coronary CTA? How important were the guidelines, and what are you seeing in terms of the trends of adoption?
Well, yeah, excellent question. And, obviously, for me personally, I think the guidelines are the foundation of the success that we have today, to be quite honest, because those were the first multi-societal document that brought forward evidence-based data that showed that coronary CTA actually has its role that we all are aware now, and probably we're aware there, but we needed this paper in our armamentarium to prove to people who were on the fence, who were basically just against it, to show that patients with no known coronary disease and with chest pain should have a coronary CTA as a first-line test and not undergo all the other tests that were historically part of the chest pain evaluation. Me personally, I think that it is a fantastic conversation starter, if I may say so, to explain to people who are very much on the fence or who are, coming from a different point, whether it's a nuclear cardiology physician or whether it's a family physician who has been doing things differently for a long time, to say, okay, it's not just my personal opinion, but this is the evidence that we have based on multiple prior trials and also supported by multiple both cardiology and radiology societies, which I think is important to have all these parties on the same page. So overall positive and literally the foundation of what we do today.
I like to think that a lot of the changes actually occurred even before the guidelines. At least people in the know, which is a lot of our referring physicians, cardiologists, they certainly knew about the trials that informed the guidelines. They came out years before the guidelines. So, I think adoption actually started before the guidelines. But when we now have those conversations with folks who maybe haven't been paying attention to everything that's been happening in the cardiac CT world, the guidelines is a great kind of place to start the conversation.
When the guidelines came out, something that I noticed in the outpatient imaging world, even though it's related to the chest pain guidelines, I've noticed that when this guidance came out, we saw a lot more primary care doctors starting to refer to coronary imaging, coronary CTA specifically. This was historically, anytime patients had suspected coronary artery disease or they always seem to try to send them off to cardiology and hand them over that way. I've seen a lot of primary care doctors now really trying to, look for the disease process that they're trying to prevent. We know that they're treating them for hypertension, diabetes, and all these risk factors. With this change of recommendations, Class 1A, they're going to these conferences, they're getting educated, they're feeling more comfortable ordering this imaging, seeing whether or not they can keep their patients, manage them appropriately medically, or send over to cardiology. So this has been great in the outpatient world, where our highest increase in volume when it comes to who's sending to us, we've seen the biggest increase when it comes to primary care.
Yeah, and I think to your point, Ron, I mean, the papers were amongst, I'm going to say us, so people who are doing cardiac imaging, but the broader reach to people who are not doing cardiac imaging, as Mike was pointing out, was via the guidelines, and it's primary care, it's internal medicine, and it's patients themselves who hear it through media and social media, particularly.
A lot of that.
Yeah, no, it's great points. Fully agree. I guess the topic now that cardiac CT has a class 1 indication and more available and more used, the question is, well, how do clinicians select between coronary CTA and other stress tests like a stress echo or a SPECT or a PET? So certainly the guidelines try to give some suggestions there, but this is a common question we all face. So Marwa, what is some of your advice that you give your referring physicians in this manner?
Thank you, Ron. And I would anchor it actually in the guideline document. It is a guideline document. It doesn't mean that you have to do it this way for every single patient, but it gives you a general scope where to go. And I think the guideline provide this sort of general advice where coronary CTA perhaps should be preferred for patients that have no prior history of coronary disease. So it's mostly for patients where we don't know the state of coronary artery tree or prior sort of events, patients that didn't have prior events. It is recommended for patients at a moderate risk, probably in the sort of a lower part of the moderate risk based on the clinical presentation, although it doesn't exclude the higher risk as well, but perhaps there. Patients that are younger, the guideline use the age cut of 65, but as I said, this is not a hard cutoff point. Certainly, there are some older patients that would benefit from CT, but again, patients that is 50s, early 60s, that's really the population that we also had seen in the clinical trials, so it reflects the clinical trials data. And then the very, very important is, which I really use a lot in my practice, is when I have the clinical question of, does this patient have not only obstructive coronary artery disease, but also does the patient have coronary atherosclerosis? Does this patient have a plaque? I think that's a very important question, is that, as Michael pointed it out, I think even primary care, family care physicians are asking more and more. And as is critical as we have now growing armamentarium of preventive therapies to actually change the fate of patients that have coronary atherosclerosis. We are in clinical medicine far beyond the practice where we detect obstructive coronary disease. We are in practice, every one of us is in practice of preventing events happening and preventing atherosclerosis. And I would submit that we are actually on the brink of reversing atherosclerosis. And in order to reverse atherosclerosis and fundamentally change the fate of our patients, we need to know how much and what type of atherosclerosis that a patient has. And the coronary CTA is the only test that provides it. Now, with that, I would say there are certainly areas where stress testing has a role. I think I would more use it in patients that have known coronary disease, when my clinical question is, does this patient have atherosclerosis? And can I reproduce the symptoms of the patient with the test? And the stress testing is really very helpful for that type of patient. If you're trying to reproduce that your angina, your shortness of breath is indeed introduced by physical activity exercise, and therefore it will guide you as to how to alleviate the symptoms of the patient with potentially revascularization or medical therapies. I think that's where the strength of functional imaging, whether it's with nuclear or echocardiography stress testing, is. So that would be my general guide.
Can I make a quick comment?
Great.
Simply because I'm I'm in that age group and I'm a woman. I would also argue, we talk a lot about calcified plaque in other areas, but if we look at our younger female patients where that certainly doesn't work, and coronary CTA is the means to look at the non-calcified plaque, which those will have. And as Maros said so eloquently, those are the ones that we can treat and we can reverse and we can improve their overall, quality of life probably, and their life expectancy, because by reducing the plaque that we're not otherwise seeing. And they may be, they may have vague symptoms, they may have atypical symptoms, as women often have, and only coronary CTA will show us that. And I think that is an often overlooked and underestimated potential of coronary CTA to serve actually younger female better.
If I may make a quick comment, the comment was made about being on the brink of plaque reversal. I think we're past that. I'm actually seeing this almost every single week at this point. So finally, I'm getting follow-up imaging with plaque analysis from patients who had imaging done in 2020, 2021. Now in 2024, I'm getting their follow-up imaging, and I'm seeing real plaque reversal for the first time in my career. Not just a little bit, turn your head, squint, maybe it's a little better, but actual going from a 60% down to 25%, huge reduction in plaque burden. If we're looking at the plaque spectrum, we're seeing a shift from non-calcified to calcified within that actual lesion. The biggest additions that I've seen, and I'm, hopefully most of the time I have access to the clinical notes, and anytime I see real plaque reversal, I'll try to bring that up and see, what are they taking? What are they doing? And what I've noticed the most is they're dropping their LDL down much lower than historically. If you look back, a decade or so, normal might have been, around 100, something like that. Then it keeps going lower down to 70. The patients where I see real plaque reversal, they're well below 60 on their LDL-C levels. And some of them with the PCSK9 inhibitors, they're in single digits, some of them. But it's really been remarkable to be part of not just slowing down the progression of coronary artery disease, not just stabilizing it in some patients, but actually reversing it. It's tremendous.
Yeah. No, I think those are really interesting points. I mean, I would just mention, as a preventive cardiologist who does a lot of plaque imaging, that the reversal aspect is something that when we see it, it's certainly very exciting and beneficial, but we don't see it in everyone. And when my own patients ask me, I often tell them the goal is to stop it from progressing. Now, the secret is that, yes, we can see reversal in some patients. And at least my experience is that we are more likely to see that if we're treating plaque earlier on, so non-calcified plaque before it has a chance to calcify and fibrose. So certainly we don't see reversal in everyone. It is I think the most frequent question that patients ask me is, how do I kind of clean my arteries? Doc, do you have any liquid Drano you can just pour down my coronaries? But so certainly we can have reversal for some individuals, and it is very exciting when we see that. But even if we stop plaque from progressing, I think that's a huge win for our patients. So really important points there, and the unique advantages of coronary CTA in identifying plaque and prompting prevention. And today, prevention is not just stand. There's a lot of other therapies we're going to implement for patients who have plaque. So really great points from all of you. So given all that, there's now going to be enthusiasm by many hospital systems and clinic to maybe start a cardiac CT program, maybe double down on their efforts. And of course, a lot of questions that all three of you as experts in the field will get is, how do I start a cardiac CT program? Maybe we'll go around and we'll ask each one of you for just 2 or 3 tips of like what hospitals need to know if they're going to start a cardiac CT program, if they just want to expand their program. What advice would you give them? So we'll start with Maros.
So I will start with a couple of advices. One is to gather information about your scanners and get the resources that SCCTs actually has for starting the program. We have a starter kit on our webpage for the members to sort of educate about which scanner do you need. What do you need in terms of support, in terms of personnel and space? It's very important you have the nurse to administer the medications, electronic medical record system that supports that you have technologists that are trained and able to perform scan. Again, SCCT provide resources for technologists to teach them. And then once the program is running or before it's running, you have to work with your referring base. And Michael, Christina, I already mentioned it. You need the group of people that are enthusiastic, that understand the results of the test. So communicate with them in the initial phase, really to work and communicate the results of the test. Go maybe beyond just the report, go and pick up the phone, discuss the results that are important for the patient, and that way sort of build the referral base. I think really build with your community to create a relationship with those who order the test. Those are some pieces of advice that I have.
Christina, what would you add?
I would, because I have my former partner, Dr. Maros, here on the call as well. I would say get a report with your cardiologist if you're a radiologist like I am, and vice versa, because this is a team effort. This is not a single woman standing, I can do it myself. This you need to have buy-in from cardiology, you need to have buy-in from radiology, and you need to have two champions in both divisions, departments, whatever you want to call it, to make this happen. Because the last thing you need is someone to torpedo your efforts because they don't believe in it, and that unfortunately has happened from what I hear. So that collaboration is critical, and I think that every department or every institution practice that runs it successfully will attest to that, because you also have the advantage then to train your trainees, which you have, if you're in an academic institution, on both sides, so that you bring the next generation up to this endeavor. Because starting a program also means that you have to create a supply chain of people who will then continue your work, whether it's on the technologist side or on the physician side. And I find this very, very critical, having the opportunity to train trainees on both sides of the fence as a collaborative effort.
Great. Well, we'll turn over to Michael. Maybe also with some advice on some of the business aspects and billing aspects, if you can share that with our audience.
I am often all too involved with billing. My companies always say I'm an honorary member of their RCM internal billing teams. With cardiac imaging and all the new CPT codes and the changes from Category 3 to Category 1, it's important to be involved. You won't have a program for long if you're not billing correctly. So when it comes to building a program, it really depends on what is your setting. Are you talking about hospital setting? Are you talking about a smaller outpatient setting, 2 to 3 offices in one single geography? Are you looking at 10 offices potentially throughout one single state, multiple states, 50 offices, 100 offices? The challenges that you get really depends on what where your starting point is, what does your group look like, and what you're trying to accomplish. So if you have a office where it's, say, 2 to 3 offices in one particular region, the focus really needs to be on, as was mentioned earlier, looking at your hardware and protocols and scanning acquisition. That might be one of the harder parts of that. When you start expanding into the business of cardiac imaging and multiple offices, dozens of offices, you really need to take a step back and realize the easiest part of all this is actually scanning the patient. We have good established protocols for that. Take some education, but that's actually the easiest part. The hardest part is everything related around that. When I start a cardiac program, the very first thing I look at is I survey the territory. What's our starting point? What's your hardware you're working with? What's the rotation time? What software packages do you have on there? What's your support staff look like? What's your post-processing software? You need to know where you're at and then start to build from that. But you need to start in the entire workflow, not just related to the scanning. A lot of times cardiology or radiologists, they are in their in their environment, which is, the reading room, the scanner, and what they see. But if you're really looking to expand the business, you have to start from the first part of it, which would be potentially the order forms. What sort of order forms do you create? How do you make sure exams are scheduled correctly? What CPT codes is it going to be? How do you receive that order? How do you route that to the correct facilities performing cardiac imaging? The days in which you have technologists, the whole process from billing to IT, what gateways you're using, your contracts with your vendors, there's a lot. So my recommendation is to anyone who's starting a cardiac imaging program is to determine what's your starting point, what are you looking to accomplish, and then think about the entire steps. If you design a program that is able to be scalable to multiple centers and reproducible, it's not going to break down as you grow. I would suggest standardizing the process, becoming well aware about how to bill correctly, being on top of how scans are being performed for quality, educating your technologists, and also really educating your referring clinicians about the services you offer and get feedback from them. I've become a better radiologist by talking to my referring clinicians. I changed the templates up for our groups based on good feedback from clinicians about what they see valuable in the reports. And that's really how you grow the business, and it's scalable as you add on more practices.
Well, really good points from all three of you. I'm just going to add two of my kind of important tips that I think is important. You mentioned quality, and I just want to double down on that. So quality is so important for cardiac CT. So it starts with really good hardware, really good training of your technologists, and obviously expert readers. So I think cardiac CT, like every other imaging test, is highly dependent on good quality. In the second one, going back to what we mentioned on prevention, when we report cardiac CT, to make sure that we use recommendations. So the CADRADS 2.0 document specifically has recommendations for preventive therapies depending on the amount of plaque. And I'm a huge fan of putting that in reports. And I have to acknowledge that 15 years ago, I didn't like to give people recommendations because I wasn't always very certain about what we need to do. And today we have that certainty, and I found that physicians really appreciate those recommendations. Specifically, we now have seen a significant increase in payment in coronary CTA, but I want to remind everyone that CMS said that this is a temporary increase. They are looking for more data in the future before they say this is going to be more permanent. And of course, every payment increase is always temporary because Medicare and CMS, they actually come up with a new payment system every single year. So if we want this to be sustained, what are some of the things that hospital systems need to do? So maybe I'll turn over to Maros to give us his thoughts on that.
So I think the number one is that we, as the physicians that performing this, we that run our programs, have to be proactive. I mean, this is the time when you meet with your administrators, you make sure that you understand what's going on, and SCCT provides resources for that. So go to the webpage, watch this webinar, and learn more about where we are with the reimbursement, and then work with your administrator to make sure that this is going to happen, that they actually put this into their software, that they bill, and then be there. And this is going to be the hard part. Be there to help them where the rejections, the refusals come. And we will have to sacrifice our time in this initial phase for the better, good, and long-term outcome. It will probably take us more to work with administrators to help with those rejections. I think that will be critical.
So I guess what the society and others are asking every hospital payment system to do, every hospital system to do, is to submit cardiac CT charges under a different revenue code. Because the whole reason why coronary CTA and other cardiac CT services were kind of being paid too low is they were kind of associated with the wrong revenue code. So does anyone have advice? What's the revenue code? And to tell us more about that, maybe I'll turn over to Michael and then Christina. Tell us a little bit more about what revenue code should hospitals be using and why it's so important to change to the appropriate revenue code.
Hospitals, outpatient, they need to use the revenue code that they deem appropriate for them and how they use their resources. But we know that for cardiac imaging, that resources are involving multiple different departments, and that doing a coronary CTA requires resources that are different than if you were just to do a CT rule-out PE study. And this is not just one facility is going to be saying this is only unique to them. all the facilities are going to be having the ability to administer nitro. A lot of times for hospitals, heart rate control. Outpatients sometimes a little bit different. They're still going to have increased hardware expenses for better scanners. So, as was mentioned earlier, it's really important that radiologists, cardiologists, anyone who's involved with this process is involved at looking at making sure things are being billed correctly under the appropriate revenue code. If a facility is not using a cardiology revenue code, engage in that discussion. Why does your hospital feel that that is not an appropriate revenue code to use? Are they getting some sort of pushback elsewhere? Were they not aware that they could bill under a cardiology revenue code? They may not have been aware. This is, some newer changes over the last year where things hopefully aren't going to be getting kicked back anymore. So engage them early, find out how their things are being billed. If they're getting denied, engage in conversation and try to get things paid out. It's going to be really important to be involved early on.
Yeah. No, those are great points. And in fact, when we met with CMS over the last few years, we made the point that a cardiac CT in terms of its resources is much more similar to a stress test. We're measuring blood pressure, we're monitoring the EKG, we're giving medication. So I think a good general tip is to go back and look what is the revenue code that's used when you're billing for a stress test. And some hospitals have specific revenue codes for stress tests. Sometimes they're called cardiology revenue code. But they actually have nothing to do with cardiology or radiology department. And I want to ask Christine a little bit about her advice because, it's very apparent to all of us, this is not a cardiology or radiology issue. What revenue code do you choose to bill? It's more a reflection of what resources are being used. But Christina, what are some of your points specifically on revenue codes and to make sure that people understand what's the difference between a revenue code and an actual department?
Well, I think since this is, as I mentioned, it's a joint endeavor between cardiology and radiology in most institutions. But there's always the fear that one or the other takes over. And if a cardiologist hears, oh, you have to bill if a radiologist hears you have to bill a cardiologist code, there may be a misunderstanding that then the money, the billing, whatever goes to cardiology, which is a misconception. But that is something that I've heard, and people have been hesitant because of that. And I think it is very important for us to bring the word out and to ensure people that it's simply a code that is applied to the exam, which has nothing to do with who ultimately gets the money.
I'm really glad you clarified that because it is a source of really kind of misinformation or misunderstanding rather. The payment is still going to the hospital. It's always gone to the hospital. Hospitals will just get more now. So it's not us, the physicians, who are getting more. It's the hospitals that are getting more. And it's not the cardiology department or the radiology department. We're all talking about payment to the hospital. But hopefully more money to the hospital means they can also invest more in cardiac CT because they're the ones who are paying for the CT scanners and for our nurses and for our techs. I must say, sorry, can I add one more thing because we didn't talk about this. More money for the hospital means the potential for more readers, which is something that we struggle with. I don't know if others do, but we're short of staff. We're short
too.
We're short of.
Yeah, I think we're all raising our hand on that one.
Right.
Yeah.
If anyone knows anyone, we're hiring.
I mean, it's we're playing musical chairs with too many chairs. Because we're all moving about the country. But, I think that, having more money for for the work that we do will hopefully encourage the hospital to provide us with more money, and then eventually with more people who are willing to read, because that's a huge struggle, particularly with the increase of studies and cases that we do every day.
Well, I want to thank all three of you. I mean, it's really a terrific opportunity to talk to the three prominent leaders in the field of cardiac CT in this very important moment. We're literally having this conversation moments after the CMS payment rule has come out. There's certainly going to be many conversations on this, but at the end of the day, I think this is a very positive development for hospitals, for the field of cardiac CT, and most importantly for our patients, because we're hoping that this will lead to more investment and more access to our patients and better quality cardiac CT. So again, this is Ron Blankstein on behalf of our speakers, Maros, Michael, and Christina. Thank you all for joining us.
Thank you all.
Thank you for having
Thank you
us.
for having me.